This is Mark Kris from Memorial Sloan Kettering. I'm speaking today about an extremely important topic to all of us, and particularly our patients, and that is the prevention of nausea and vomiting following anti-cancer therapy. You know that when you do a survey of what are the main concerns of our patients that are about to begin, particularly chemotherapy, it's nausea, vomiting, and alopecia, or alopecia, nausea, and vomiting. It's those big three, and that is the thing on patients' minds. And the more assurance we can give our patients that we can prevent these problems, I think the better their whole outlook can be and the better the decency of their life. Please remember, there's no real treatment for nausea and vomiting brought on by cancer therapies. It's all about prevention. Decades of research has discovered that, particularly for the drugs that are very likely to cause emesis, and cisplatin would be the leader there. The other common one is the combination of cyclophosphamide and doxorubicin used in adjuvant treatment of breast cancer and other cancers. If you get those, or if you receive those regimens, you're going to have nausea and emesis, and you need our best drugs. Years ago, research has shown that a 5-HT3 antagonist, dexamethasone given for several days, a NK1 antagonist, and lastly, olanzapine given 4 drugs is the recommended best therapy by guideline panels. And I'm going to pick on the NCCN and the ASCO is, I think those are the ones that most of us use. It's clear that all 4 of those drugs need to be done. And I'm going to talk about that great paper in the New England Journal by Dr. Navari that showed olanzapine 10 milligrams with dexamethasone, with a 5-HT3 antagonist, and with an NK1 antagonist. That was the best. By the way, that trial was about as pure as you can get, multi-center, randomized, placebo-controlled, not sponsored by pharma, funded by your tax dollars. It was perfect. But the interesting thing about it is that folks just didn't embrace it. They particularly didn't embrace the olanzapine. And the beautiful thing about the olanzapine, though, is it controlled the biggest problem what we have now, which wasn't vomiting, it's nausea. And in that Navari trial, the control of nausea went from 22% without olanzapine to 37%. And this is prevention of nausea. So that was big. What I'm doing, why am I doing this today? There was a paper published in Lancet Oncology by Bajpai, Bajpai, Bajpai. And in this paper, it was a randomized trial that compared an unconventional antiemetic regimen that really didn't contain multiple days of dexamethasone with 2.5 or 10. And what they found was really not good at all. Their complete control rate, what they said was only, quotes, mild nausea and no vomiting, was only 44 and 45% in the 2 arms. So the majority of patients did not have so-called complete control. And so-called total control, where people had no nausea, it was 14 versus 16%. So those numbers are really inadequate. And what particularly concerned me in this trial is this wasn't a trial to see if something was better. It was a trial to show non-inferiority. So why would we want to show non-inferiority for regimens that are clearly inadequate? It just made no sense to me. And it really, I guess, got to me because this is the greatest concern of our patients, nausea. And we do have drugs that can help with nausea, and we can do better. So a couple of things. Number one, please use the guidelines that are out there now. They have been developed over nearly 40 years. It's extremely safe. They're available. And please use them and use them religiously. Please listen to your patients. The prevention of nausea is absolutely critical, and I would pull out all the stops to do that. look for ways that we can do a better job. And it is kind of tough, actually. The one class of drugs that's out there now would probably be cannabinoids, and those deserve, I think, to be tested, particularly to treat nausea. The other thing that's happened is folks have tried to shy away from dexamethasone, but I caution you, there is no body of evidence that says that by giving dexamethasone, you somehow impede the effectiveness of regimens, particularly those that contained checkpoint inhibitors. I will tell you that both the NCCN and ASCO guideline committees have carefully addressed this, and there really is no evidence that dexamethasone given as it is as an antiemetic causes difficulties. And by the way, checkpoint inhibitors themselves, they're a low emetogenic risk or minimal, and they do not require any antiemetic of any kind, frankly. So pay attention to the patient's needs, use a standard regimen. Please, 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 we need to do better here. Having trials that show equivalence of truly inferior regimens make absolutely no sense to me. We owe it to our patients to do a better job. And we owe it to ourselves to strive for more than to show that two inadequate regimens are equivalent.